Hi, my name is Heather Peabody, and I'm an occupational therapist from Nashua, New Hampshire. My company is Vital Spark LLC, and my website is www.thedementiaspecialist.com. This is episode 4 in a web series on caregiver expectations with dementia. We're looking at different aspects, and you'll have to excuse me on the different formats of the videos. I'm trying to get these up as fast as I can using my iPhone and my iPad. I'm having some technological difficulties, but I think it's important to get the word out for you. So, we've already talked about global deterioration stages 1, 2, 3, and 4. Risberg, Ferris, and Cook in the early 80s had found that clients with chronic and progressive dementias lose skills in the reverse order that they developed them, and they happen in these milestones, kind of age equivalents. And it's supposed to help you in your understanding of how people process information, not to tell you to treat a client like a child, but to understand that clients have different levels of capability and to understand their emotional processing and cognitive processing and teach them within their level of capability. So always treating your client like an adult, but giving information and cueing and supervision that you may to someone of a certain age equivalent. So this stage is moderately severe cognitive impairment, level 5 on the global deterioration scale. And what Risberg has here for an age equivalent of a GDS of 5 is a 4-year-old. And I disagree. I like to compare functionally. I think the client can function similarly to a 12 to 13-year-old. I think this really is the teenage stage of global deterioration when the client gets to a mid-stage dementia. Some clinical characteristics of mid-stage are similar to what you see with a teenager. Like, you probably want to check their clothing before they go out, seeing if it's weather appropriate, seeing if it fits properly, seeing if it is socially appropriate. Just like teenagers, you probably wouldn't want them to self-medicate a new condition because they may over-medicate, under-medicate, or not take care of a medical issue. You would want to monitor for nutritional choices. What are they going to eat? While a 12 to 13-year-old may be trusted home alone for a period of time, you would want people in their life to periodically check in on them. How long do you leave a 12 to 13-year-old home alone? Well, I think that would depend on the 12 to 13-year-old, so we really have to take this on a case-by-case basis. I looked up what would be considered a parental neglect for child supervision for the state of New Hampshire, and a 12 to 13-year-old could be a babysitter for other kids, and a 12 to 13-year-old could be left home for 24 hours or an overnight, depending on if there are neighbors in the area to keep an eye on them or how close they are to a food source and things being prepared for them. So if someone were to go home at a mid-stage dementia, we want to make sure that they are checked on periodically if we were to base it just on that level of cognizance. So Meals on Wheels is a great way to have a person have a little look in. Having some phone calls from family caregivers and nurses. Hey, what were your sugar levels this morning? Okay, have you taken your insulin yet? One thing is also you could lay items out as a setup for your clients at mid-stage. So maybe a caregiver stops by the house in the morning, lays their clothing out that they could wear for the day, maybe prepares some meals, and then will leave. Some family members have a part-time job or a full-time job, and they could leave for a little while. I would definitely give my client a medical bracelet that says, "A medical emergency, please contact so-and-so." Please don't put on the bracelet, "I have dementia, I have Alzheimer's," because it basically says, I am vulnerable, take my money out of my pocket and, involve me in your next scam. So we want to have the neighbors know that the client has some memory issues. There's a wonderful website, zarcrom.com, the Alzheimer's Outreach. www.alz.zarkrom.com, and these are linked out through my resources on my website. There's a letter that you could print out and say, hey, my mom has dementia, and if she ever comes over to your house and she seems kind of confused, can you give me a call on the phone? Generally she's pretty good, but if she ends up having an illness, it really does compromise her ability to concentrate and function. If you're not sure whether this client should live home alone based on their deficits that they're having, you could always do home care services. We could offer 24-hour supervision through guardian angels, home care associations. In New Hampshire, we have interim health care, home health and hospice, the Visiting Nurses Association, and then you have some non-medical caregivers that could give some supervision to your client, like guardian angels, or you could put out online. They have care.com, where you could find caregivers, essentially someone to help watch and supervise your loved one who doesn't necessarily have a medical background but may just be there to keep them company. Maybe they're their professional driver, errand boy, professional shopper, buddy, whatever it is to keep this person around and give them the supervision that they need. And many of these companies provide services to help decrease those frustrating expectations at home, like cleaning the house, vacuuming, washing the dishes, doing laundry, making sure things are set up for the house to, optimize the care. Even though the client might be very capable of doing all of those things, it might just be taking too much of their cognizance to focus on it and easily frustrate them. Other expectations at mid-stage, we have to make a choice. What is the long-term plan for your client? Are they eventually, when their cognition declines, will they be going to a nursing home? Will they be moving in with their kids? Do they have a spouse to take care of them? Whatever it is, if you can keep the routine as long as possible, you will preserve the highest level of function. With dementia, repetition is a substitute for memory. So when the clients are doing the same thing every day, they don't have to remember as many things. And with dementia being chronic and progressive, once neurons die, skills are lost. And once skills are lost, they're very difficult to get back because there aren't as many healthy neurons to relearn what they lost. So with dementia, it's always kind of a subtraction problem that when a client loses a skill. And what family members notice is if their loved one, especially if they're in mid-stage dementia, if they had a medical issue and they needed to leave home for a period of time, this client will become very confused when they get to the hospital or subacute rehab. And usually the medical team will look at the family and say, wow, I don't understand how this person could have possibly been living home alone, because seeing them in this new environment scares me. The client who has a mid-stage, at home they had the routine, and that's why they were functioning so very well. It was the routine was substituting the new learning. When the client moves to the new environment, the hospital, they have to put on a patient gown. It goes on the opposite way that shirts do. They have to use teeny tiny toiletries that are not familiar. They're not the same of what they had at home. The environment's unfamiliar. The rules are unfamiliar. The people are unfamiliar. So oftentimes you'll have a big confusion. And even if therapy takes the client into their therapy kitchen or therapy bathroom, we can never simulate exactly what the client had at home. So if you could request it, try to ask therapy to take the client back to their house for a home visit for discharge recommendations. And I strongly recommend, if the plan is for the client to go home, get them home as soon as possible so that they can still tap into that residual ability of their routine. Because if the client is far away from home for a long period of time, they will eventually forget that routine that they had at home. And if they do go home, say 3 months later, they'll probably need a lot more help to go through their day. So, what do? Should we make a change and have the client move to a nursing home if they get ill? Should you move in with the in-laws? Should you stay home and try to age in place? These are all very personal choices that you would make as a family member, and my only advice is knowing that change is a causal event linked to cognitive decline. So every change we put in the client's life will see a loss of ability. We have a very important choice. Here's what I say. if change is inevitable, we're going to have a change of household, a change of medical supervision, a change of environment, whatever, don't delay. Make that change sooner rather than later. So when the client has the change, we can preserve the highest level of function. Don't delay change, because if you wait for a cognitive decline to make a change, then they're going to have another cognitive decline. For example, let's say a family member says, well, when my dad has his cognitive decline, I'm going to move him to assisted living. Well, what you'll have is someone who's living at home has a cognitive decline, and then they move to a new environment. Well, that's 2 cognitive status changes. If you had the client move earlier, before they had the cognitive decline, well, they have a higher level of cognizance for only having 1 cognitive decline, and they're at a higher level of ability, so they could learn their routine, make their friends, acclimate to the new environment. If you move them after they have the cognitive decline, they may not have the cognizance that is appropriate to live in a long-term care, and then they end up going to the hospital and going to the nursing home anyway. So avoid change whenever possible to preserve the highest level of function, but if change is inevitable, make that change sooner rather than later. And that's the best advice that I could give you. I really can't help you decide on a individual basis.